When you hear that trumpet, you know it's the Dr. Larry Show on the Bachelor News Radio Network. And tonight I'm Dr. Larry Fedewa. I'm your host for the next hour. And tonight we are developing another aspect of our series on healthcare in the United States of America. And we have I'm going to give a couple of the key points of the proposal that I have made in my own assessment of this problem. But we are then going to be introducing some real experts on this field, and they are going to they have co-written a book called "Our Healthcare System is Killing Us." So that's kind of a wake-up call. The key points of my program were that our goals were to develop two of them: to develop a patient-centered healthcare system where the patient is the buyer and the decision maker of his or her own health care, and secondly, to reduce the cost of care to the patient by a goal of 2/3 of the $4 trillion that were spent in 2018. There are certain obstacles to this idea. The first was the shortage of medical personnel. Dr. Cragen a couple of weeks ago told us that there is a potential and predictable shortage of physicians, and that does not include paramedics and other medical personnel. 100,000 lacking in covering the United States of America. So we figure that that's a major. It's not only a cost driver, but it affects everything. Our solution is that we think that there should be a ROTC program for medical students. If we can support our military by accepting students that will give 2 years of their practice after graduation, then we feel that they ought to be able to try to alleviate this current and coming major problem. Secondly, we have taken the biggest, probably the most visible thing that we are predicting is that we would like to see the employers removed from the responsibility for employee health insurance. They would love to be out of that business. It's a distraction and it's a very heavy cost, and it also inhibits the starting of new companies because the capital costs, if you have to give healthcare to your employees, is prohibitive in many, many cases. So that would be good for the economy as well. Then the federal government obviously plays a major part. There's approximately 40% of all of the funds that are spent with the federal government, with the medical care, are involved. The federal government is involved. So we would say the following. One, the federal government should maintain the Medicare system because of ethical and legal obligations. Mainly, people have been paying into the Medicare fund for their whole career, and they expect that it's going to be there when they retire, and it should be. It's an ethical and legal responsibility of the United States. However, the federal government, that's about it as far as the federal government's direct involvement. We're also saying that we ought to get rid of the 50 state. We ought to make the federal government ought to make medical insurance an interstate commerce industry, because right now there are 50 states, and that means that basically 50 different insurance companies have to be within one insurance company if they want to cover the entire country, and of course many of them don't. So there are places in the United States where there's no insurance at all. So we say one set of rules: let everybody that wants to get involved in a cooperative or a credit union or church or whatever group that you want to get together and form an alliance to buy your health insurance, that you ought to be able to do that. And then the final thing that we're asking the federal government to do is to set limits on what they call tort reform. It set limits on medical mishaps so that we can end the need for defensive medicine, which is another major cost driver. For the state governments, we're saying that basically they should be limited to licensing the medical personnel, as they do for other fields. We think that the state government should be managing a pool of funding for indigent patients based on a small per capita tax of each buyer of health insurance. And this is a critical component of universal coverage. We think maybe a restructured Medicaid program without federal government might be one of the answers, but it needs to be there to take care of the people that can. If we can have take care of people that are starving or people that are in great need in other areas, we will also do it in health insurance, but we ought not to do it the way we're doing it now. The next one is the oversight of the standard business procedures. We think that any type of or any group of people, citizens who want to get together in a church or union or cooperative, so small business association, neighborhood, any other type of structure. This feature is a key to lowering health costs by increasing competition for the patient dollar in the extended field offered by a reduction of individual state retirement requirements and an end to defensive medicine. And then we have the insurance companies, who are right now an obstacle to their major cost driver. And we're saying that there's still a place for insurance companies, but it's mostly in the catastrophic area, which is addressed to the fact that right now it's approximately one of the highest causes of family bankruptcy in the United States of America today is medical bills. So this whole program has to really be shaped up and give us better treatment for less cost. And finally, there are some differences in how the average person would deal with his or her health care, but the main one is that instead of getting your paycheck with the deductions for your premiums, you would get that extra money in your own pocket, and that's the basis for your health savings account and your other needs. So with that, I would like to introduce Dr. W. Terry HOWELL and Dr. Aaron Fausz, who are experts in this whole field, and it's about time we got some really strong people to look at the reform issue. And gentlemen, welcome to the Dr. Larry Show.
So, thank you, Larry. I think Aaron. This is Terry. And I think Aaron was going to talk with you first about what we wanted to talk about today.
Right. Yes. The second half of the opening statement is going to be Dr. Aaron Fausz.
Yes, thanks, Dr. Larry. A pleasure to be on board here with you. Just imagine moving from sick care to an ideal healthcare system. The U.S. healthcare system desperately needs radical reform to rein in costs, reduce harm, expand access, and become consumer-centric. Imagine a healthcare system where consumers are respected and in control. Imagine communities focused on prevention and health. Imagine a system where drugs and surgeries are more affordable and effective. Real change requires disruptive innovation. As citizens, employers, entrepreneurs, healthcare workers, elected officials, and patients It is time for us to drive the change. In our new book, Healthcare is Killing Us, The Power of Disruptive Innovation to Create a System That Cares More and Costs Less, we explain how we can disrupt, dismantle, and rebuild. We ask the question, will you be among the daring disruptors creating the ideal healthcare system of tomorrow? And we put forward a cogent pathway from sick care that is killing us physically, financially, and spiritually into a compassionate, affordable, and risk-free place for everyone to live longer, healthier lives. We ask that you don't just imagine. It's time to start to doing something.
You're listening to the Dr. Larry Show on the Bachelor News Radio Network, and we're talking with two experts on this whole healthcare system, Dr. Terry Howell and Dr. Aaron Fausz. And Aaron, that's a pretty strong exhortation you just gave us. What do you see in the practical world of this disruptive intervention and original creative thinking?
Yep, Dr. Larry. We see a number of factors that are forcing disruption. In fact, we think of it as the perfect storm for disruption in healthcare. These include just as you know, the rising cost of healthcare. It's been up over 250% in the last 20 years, when inflation was only up 50%. It includes the aging of our population. As the baby boom generation gets older, we're all getting older, but in particular the baby boom generation, over 10,000 people per day in the United States age into Medicare. That is, they turn 65 years old. That's 10,000 people a day. Our healthcare system is ill-equipped to deal with that. We have over 50,000 pediatricians currently in the United States, but less than 5,000 geriatricians who are trained to take care of the elderly. Chronic illnesses are sweeping the country. It's truly an epidemic of illnesses: heart disease, kidney disease, diabetes, hypertension, or high blood pressure. These are where 70 to 80% of all healthcare dollars are spent, and the reality is these are preventable conditions and preventable diseases if people would be able to change their behaviors and modify how they live their lives. And then there's also a slew of innovative competitors who are free market oriented, who are price sensitive, who are now coming online and making their services available and making it easier for people to act like consumers of healthcare.
Can you give us a couple of examples of those free market programs?
Absolutely.
Go ahead, Harry. Well, I've got a favorite. It's the reason I wanted to answer that one. There are many. First of all, the employers are simply fed up with the cost. All of us are. I was in healthcare for 30 years. I was in the C-suite. I kind of know that world. I was consultant as Aaron has been, and we've worked very hard to try to reduce costs. But we need major changes, and so I'd like to answer your question by talking about this company called Iora Health, I-O-R-A. So there was a young man who got out of medical school at Harvard, and he worked in one of the big hospitals, and Aaron and I have been in tons of them across the country, and he was just aghast, and he said there's three things wrong with healthcare. One is it's fee-for-service, and so when you have fee-for-service, it's well known in the industry that you get about 30 to 35% more care than you need. We call it overutilization. It's just the fact. Why? Well, if you pay people for services and procedures, you get more and more services and procedures. The second thing he said was wrong was that we spend way too little on primary care. 3 to 5% of our dollars are spent on primary care, and that's completely upside down. And the third has to do with technology. I'll set that aside. He makes a good point there. So he decided to start a company. He got $6 million in investment, and he got 5 companies across the United States, and he said, we would like to go at risk. What that means is you pay us a certain amount each month for all of your employees, and we will take care of their health care for that amount. And it was usually the employees and their families. One of the places he did this was the Dartmouth University. Another one was in Las Vegas. It was company that was managing a lot of the union retirees. And so there are different companies across the United States, and he was saying, we want companies that will insure themselves. We will go in and we will take care of your folks. And so what he did, he hired a lot of primary care people, and then a whole lot for each of his primary care physicians. He hired 4 health coaches. And these health coaches are, $15 to $20 an hour people without a clinical background, but they have empathy and care and concern for people. And so they go into this population of, these companies, and they look at the data, they look at the risk, and they sort of stratify by risk, and they start coaching and helping and supporting these people to make the lifestyle changes that are necessary to keep them from getting those chronic illnesses or to help them get out of them. And that's not something that you treat with 3 visits to the doctor a year and, pills that suppress symptoms. It really requires a healthcare change. But long story short, with this methodology of having a lot of primary care, a lot of attention, they had Zumba classes, smoking cessation classes. They would actually go into people's home and help clean out their pantry and help them actually shop for the way they should eat with with diabetes and so forth. They were able to reduce the number of hospitalizations at these 5 different companies by 40%. Wow. And Larry, the real cost in healthcare, it's not so expensive to provide health care, but if you provide it in a hospital, it's incredibly expensive. 65% of the cost in a hospital, in your hospital bill, is fixed cost. That's because you have to keep it open 24 hours. You've got environmental services. You've got dietary. You've got staff at 24 hours. So it's very expensive to keep a hospital open. It's administrators. It's fixed cost. If you can provide that care outside of the hospital, it's a lot cheaper. And if you can keep people from going into the hospital, it's a lot cheaper. And so they were able to reduce the number of hospitalizations by 40%. And for these companies, on average, they were able to reduce their health care costs by 25%. Now, there are more and more companies out there like that are focusing on what we call at risk. In other words, their job is to keep you healthy, not just to fix you once you're broken. And this is, I think, going to make a huge change. The politicians, who I know you work with quite a bit, they spend a lot of time talking about how to pay for health care. And while we need to answer that question,
that's all they talk about.
I know, but that's because they don't know that what we really need to ask first is how can we reduce the ridiculous, expenses that are inherent in health care. 50% of the cost of health care in this country is wasted. And I believe that. It's been documented. It's not just, nothing we say in our book, we say just out of our experience, although we've had a lot, it's incredibly well researched. So we need to ask the question, why should we pay for this sort of monstrosity when we can provide better care probably for a whole lot less and maybe a lot safer? Because if we can keep people out of the hospital, then we don't harm we actually kill 250,000 people a year in hospitals. And that's a conservative number out of Johns Hopkins. Oh, that's true. Don't go into a hospital unless you have to. It's a dangerous place. So our book is not about just beating up healthcare. We've lived in it. We've worked in it. We have great empathy for the providers who are overwhelmed and burnt out. The system itself needs to be totally disrupted and rethought. And we think those forces, like I just described, IORA, are going to be part of redoing that. Aaron, why don't you also tell them about the Centers of Excellence and how that's changing the way we provide care, too?
Absolutely. There are several different approaches to this. One is the Employer Centers of Excellence Network. And this is a coalition of businesses who have gotten together and identified a handful of providers across the country who excel in various procedures, mainly high-volume procedures that a lot of people are needing. It's joint replacements. It's spine and neck surgery, it's bariatric surgery. They've identified a handful of providers who, one, price their service to here's what it's going to cost. Two, they excel. They get better health outcomes, better clinical quality, better outcomes for the patients who are undergoing the procedures. And three, they really know when those procedures are necessary versus when they're not. So a local doctor may suggest, hey, you need to have back surgery or neck surgery or have your joints replaced. These centers of excellence can look at that, and 20% of the time they say, no, that's not necessary. You need to do something else instead. Lose weight, participate in physical therapy or occupational therapy or something else more clinically appropriate. So these patients for these companies that are members of these centers of excellence, if they need one of these procedures, they will fly first class to one of these hospitals. They will undergo the treatment there. They will recover there at the hospital or in a nearby hotel and then return home. And the cost savings will be 30 to 40% less than having that procedure done down the street from where they live.
My God, why?
And we're talking about flying them to Mayo and Geisinger and Cleveland Clinic and some of the really top drawer organizations. But if Walmart has 2.4 million employees and then all of their family members, you got 10 million people. They've got a whole lot of joints and spines and so forth. They go to Mayo or down there to Emory or other places and say, we can send you a lot of business and we know your quality's great, but we want to see your quality numbers. And but we've got to have a really reduced rate, and we've got to make sure that you don't provide care where it's not needed. Millions and millions of dollars currently are being saved by these organizations that are using these centers of excellence.
You're listening to the Dr. Larry Show on the Bachelor News Radio Network, and we're talking to Dr. Terry Howell and Dr. Aaron Fausz. And Aaron, you were talking about the centers of excellence. How do they save so much money? Is it the 20% that they don't pay in surgeon fees, or what?
Nope, they make up for it in guaranteed volume. So Walmart, Boeing.
So they get reduced prices.
They more accurately capture the actual cost of these procedures, but they know they're going to get increased volume from these employers who are sending all their patients to their facility.
So what about their capacity? I mean, if you took Walmart and you got 10 million people, that's going to require a lot of capacity.
Yep, they've been able to handle it thus far, and most hospitals, if they need to ramp up, they can ramp up. And these places are focusing on these handful of procedures, and they know we're going to be doing more of them. We are going to be the center of excellence for this. So it's something they already do they're very, very good at. They do very well. They're getting good outcomes. They become part one of these centers of excellence. They're, instead of having people from 50 or 100 miles coming to them, they're having people from 1,000, 2,000 miles away come to them. And they're able to ramp up for that.
Plus your Mayos, it's not just a mothership in Rochester. You have Mayos. I don't know how many there are. Aaron, you've actually done consulting at Mayo, but I know they're in Phoenix and Florida. There's several in Minnesota and those areas. So, it's not just one hospital. But when you do a lot of procedures, Larry, you get really good at it. Let me give you another example of competition that you might not think about. So there's a company in India. It's a hospital, Narayama, I think. I'm not sure I pronounced it correctly. They do 900 heart procedures a month. Now, most hospitals in the United States don't do 900 a month. Yeah, it's 30 a day. Most hospitals don't do 900 a year. Now, the more you do these procedures, my brother was a cardiovascular perfusionist, and he said the more procedures you do, the better you get at it. And they all work at the very top of their skill set. So the average cost of a heart procedure in the United States is around $80,000 to $100,000. The same procedures done just as well, and in some cases better, because their quality is through the roof. The same procedures in India are $1,800. Now,
well,
you might not want to fly to India, or you might question the quality, but the quality, I can guarantee you, is probably better than a lot of places that provide it here. So what they did, they said, well, fine, we will open up a hospital in the Cayman Islands. And they're opening hospitals in Africa, places across the country. The founder of that hospital was the cardiologist from Mother Teresa. They have a great mission. They really want to help a lot of people. But the one they opened up in the Caymans, they can't do the procedures for $1,800, but they can still do it for 60 to 70% less than what it costs you at your local, heart hospital. Now, I would go to the Caymans. I would get my procedure. I would stay at the Ritz, and I'd be on the beach for a week or two and come back and still be about $50,000, $60,000 to the good. So there's that kind of competition that's coming out there too. One other thing that's really interesting, a lot of people may not know about, but one of the things we've got to start demanding, and there's some rumblings from Washington about doing this, is that we get price transparency. It may be shocking for people to know, and I always like to turn to page 86 of our book, because there is great variation in treatment from hospital to hospital, even within the same city. Just to give some examples, and these are apples to apples. So types of breathing problems, less than 4 days in the hospital. Variation in one place you go at $78,000, another it's $273,000. Heart failure from $7,000 to $173,000 for the same procedures. Total hip replacement $11,000 to $105,000. Now let me just move to the same city. So in Dallas, if you've got lower joint replacement, you could pay $42,600 or $160,000, depending on which hospital you went to. And because we've been saying for years, don't worry about it, honey, insurance will pay for it, hospitals get away with charging whatever they darn well please. Because, as you said, we're not consumers. We don't go and shop. We just, insurance will pay for it, Medicare will pay for it, and that's a huge problem. But this variation is obscene, quite frankly, and irritating. Then when you compare us to other countries, it's even worse. So that's something that when we say we need to go after the cost before we start talking about who pays for these ridiculous costs, that's some of what we mean.
Well, one of the factors that we also have been concerned about is the shortage of medical personnel, including high-level skills, but also all the way down. It's really pretty shocking. Would you care to comment on that?
Aaron, why don't you take that one?
Yeah, Dr. Larry, let me take a stab at that. So if in the current sick care system that we have, where sick people go to doctors to get treated, we have a huge shortage of physicians and providers. But if we flip that around and think of it as a health care or a wellness-oriented mindset, we need fewer doctors. We're still short of doctors, but we need fewer of them. And we need more health coaches. We need more nutritionists. We need more social workers and case managers to help people deal with their social determinants of health and their lifestyle and their behaviors that are causing those problems in the first place. So our thesis is, yes, there's a provider shortage. It's not as acute as it potentially could be if we're willing to flip the business model around and help people stay healthy rather than wait till they're sick to treat them.
Another aspect of that is we have way too many physicians that are working at the low end of their skill set. So one of the things that we talk about in disruptive innovation, when you redesign care, is moving work to the appropriate skill level. Two things. One, moving work to the appropriate skill set, and the other is moving work to the appropriate site, and I'll talk about that later. But I'll give you an example. Good friend of mine, a physician at a hospital you would know, well-known. He's the chief medical quality officer, very conscientious. He still practices. And he said, because we're in a fee-for-service environment, 60% of what I do in my practice I would not do if we were not in a fee-for-service environment. And I said, well, you mean it doesn't need to be done? He said, no, it needs to be done, but it doesn't need to be done by me. It could be moved to a physician's assistant, a PA, or an NP, nurse practitioner, and even an LPN in some cases. But because I get paid by doing procedures, I do all these procedures. Anytime you are working, anybody is working below the top of their skill set, that's waste. That's excessive cost. And so part of what we need to do is go through the care that we provide and make sure that it is being moved to the appropriate skill level. Now, we're not talking about anybody who's untrained or not trained to do, but I mean, how tough is it to give a flu shot, right? Your physicians don't need to do that. And throughout clinics and hospitals. The other thing is that hospitals notoriously have been charging 3 and 4 times for procedures that can be done much cheaper outside. So let's take an MRI. Probably if you went down to your local hospital and got an MRI, it would cost you, I would say, $2,500, maybe even $3,500 to $3,000. But I bet if you looked around, there would be an orthopedic clinic or some other clinic where you could get the same thing for $250, and I mean the same report. So what is going to happen with all of these businesses that are now, free market and going after these hospitals is they're going to start going after that commoditized care. Anything that can be done outside of the hospital, we believe, will be done outside of the hospital. And the people who will provide that care will be making more because they don't have to pay that 65% premium to the hospital, and they'll be able to charge less. So 2 things. One, move where the care goes to. That doesn't help the shortage so much, but what does help the shortage is make sure that we are providing, we're moving work to the appropriate skill level. Now, when you move to an at-risk environment, you look very hard at, does a specialist need to do this? Does a primary care really need to do this? We want right care, not overutilization or underutilization. And the physicians at IORA, actually, the primary care physicians began to talk to some of the specialty care people and say, we want to ask you a question. It might be uncomfortable, but what part of the care that you specialists give could actually be given by primary care physicians? So, in other words, how much of the care these specialists are doing could be done at a lower level, and it turned out a large percentage of that could be too. So we've got to kind of right size, if you will, the care that we give. We've got to get our really brilliant minds, specialists, working at the appropriate level and doing research and other things, and then moving the other care to great care, but care other levels could do. I think that will help to some degree. The other thing that's at work is there's a movement now where the organizations, I think Mayo is one of them, Kissinger, some of these large organizations are beginning to ask the question of medical school.
Yeah. You're listening to the Dr. Larry Show on the Bachelor News Radio Network. We're talking to 2 guests, the co-authors of a very provocative sounding book, Dr. Terry Howell and Dr. Aaron Fausz. And Terry, we were just talking about hospitals. It seemed to me there are 2 issues that have come up in other discussions that we've had. One is that in effect, the universal care that we now have de facto is really the emergency rooms in hospitals, and that they don't turn people away, and in many cases they don't collect either. and that one of the reasons that they talk about these inflated prices to the people that do have money is that they are doing all this charity work. What do you think about that?
Well, I worked at, again, I was on the C-suite of two different hospitals. Both of them were safety net hospitals. And so we saw a lot of indigent care, self-pay, which is a euphemism for no pay, and documented and undocumented and all of that. And the law says that if someone comes into your emergency room, you cannot turn them away. I mean, it's by law, we don't care where they're from, who they are, we have to see them. So, yes. But let's look into that a little bit. First of all, if you actually go into the emergency room and observe, and I've been in there doing process improvement and all kinds of things. Aaron's done a ton of that. What you'll find is about 70% of the people that go into an emergency room don't need emergency room care at the level. So we've got it staffed, very highly trained people, very expensive equipment. 70% of the people that go in there could go to another place. And so there have been companies like Fast Care and others that have started these businesses, and they make their pricing very transparent, and you can actually go there, and it's much, much less expensive. And you know how much the cost will be. So there's that. I think the other thing is if we can get primary care, health care system where it belongs, we will have a lot fewer of those people going in there. We're still going to have some. But this gets to what we call the social determinants of health. So when I was at Hennepin, and it's in our book, I was looking at our expenses, and we had 42 people that cost us $10 million. And I said, what in the world is going on? So we dug into those people. One guy was at the hospital 28 times. Others were there 5 and 8 and, all kinds of expense. Well, it turns out when you dig into it, what those people need, maybe 20% of what they need we can do in a hospital. But the other 80% is they need what we call the social determinants of health, like a place to live. The guy that was visiting the hospital 28 times lived under a bridge in Minnesota, which is 17-degree, weather with a wind chill factor of 30 below, or 20 below or whatever. And I would rather be in a hospital than be there. He needed a home. He was a little schizophrenic. Not capable of managing his own house, so we had to get him the appropriate living conditions. We had to get him food security, and so we had to involve the social workers and the housing and all of that. And that was true of just about every one of those 42 people that we had spent so much money on. I jokingly said, and it's nothing to joke about, but I said, for $10 million, we could give them all a limo and a condo. Yeah. And so we were able to work with the community and get these folks the right care, which wasn't necessarily medical care. People need to know all we offer in a hospital is medical care. And so much of these problems, like the opioid problem, for example, you're not going to deal with it by just putting people through a 30-day program. If you do that, the recidivism rate is 80%. But if you put them through a 30-day program and then have behavioral health and coaching and physicians and about 12 months of people helping you get to the right place, the job, new purpose in your life, support, then the recidivism, and this has been done study after study, the recidivism rate goes down to about 15%. So it's that coaching and support, helping people make the life change. Well, we're spending a whole...
right now the hospital is they're paying for it with the inflated fees that they've been charging the regular people. But exactly, but if you don't do it that way, somebody has to pay for it.
Well, so there's a budget in any state for Medicaid, right? And we're spending a lot of money, and it's generally after somebody gets sick. Well, if we can, and we're looking at that in the state of Tennessee right now, and not committing to anything, but we're working on that. How can we get to the Medicaid people and provide them with these social determinants of health and that kind of care so they don't end up in the hospital. That's what we're looking to do, is to redirect the dollars already being spent, because this is a cheaper way to provide care than what we're doing now. If we can keep those people out, we can spend those dollars differently and get people the right care at the right time and coaching and help and jobs and so forth, then I believe our healthcare costs will go down. So it's a matter of redirecting the dollars.
Yeah, but whose dollars?
Well, they're your dollars.
They got to come from.
They
have to come from someplace.
Yeah, they're your dollars and my dollars. There's tax dollars.
Are you talking about
Medicaid?
Socialized medicine?
No.
Nope, absolutely not.
When you start talking about social workers, it sounds like you're talking about people that work for a government, maybe not federal, but it's a lot of the time that social workers are actually funded by public funds, and who, if you're going to reduce this, you're going to get all these services for the indigent that now inhabit the hospitals. It sounds you're going to have somebody that's going to have to pay for it. I mean, these people can't live on air.
Dr. Larry, there's a couple issues here. One of which is paying for the ruinously expensive system that we have. We
already know how to do that.
Well, but before we address that, we've got to think about and figure out how to flip the business model so that
I agree.
Providers don't get paid just to treat people that are sick and to deal with things after the fact, but that they get paid to keep people healthy, and their margins go down when people are sick. So there are a number of organizations out there already whose business model is that. Companies like Iora, that Terry mentioned earlier, Palladina, Propeller Health, Evolve, U.S. Medical Management, Centene, Centurion.
So these are private. These are private companies then.
These absolutely are private companies. They're a managed care type of insurance plan rather than a sick care type of insurance plan.
Okay.
So that helps keep costs down and puts downward pressure on the prices because the providers themselves do not gain when people get sick. In fact, they get hurt and they lose financially.
Okay, but if I've got a company and I want to join Iora, then the funds that I'm giving to be in that group and every other member company, wouldn't those funds be going to our employees, or at least for the benefit of our employees? And the people you're talking about, the indigent, they aren't going to be working for my company, or else they wouldn't be indigent.
Okay, so let me take another shot at this. And again, I'm going to mention the state of Tennessee. They are really they're working through this, but here are my thoughts. I don't know the difference between a company of 35,000 employees, like maybe General Motors, and a company called the State Employees of Tennessee that has 35,000 employees. Okay, but who pays those people? Well, we taxpayers pay. Tennessee taxpayers pay for that. All right, and they are getting paid. I get that. But what could we do to reduce their health care costs? We could
but wait a minute.
Contract.
Wait a minute. I thought we were talking about indigent people that don't have jobs, and that we were talking about. We were talking about all of the personal services that they could use that would help reduce the use of hospitals, emergency rooms, and I don't see how the private companies are going to be helping those people unless somebody hires them, and that would be the state, wouldn't it, or the city?
Right. That's what I'm getting to. So first of all, let's take the employees of the state and let's reduce their costs by 40%. Okay. Now we've got some more money. Now we've got Medicaid money, right? And that's being spent. What's it being spent on now? Emergency rooms, hospitals, expensive care. It's being spent. Taxpayers are paying that. How could we reduce that? Right? This is indigent care. And this is hard for some people to believe, but when you can take your indigent care people, you have the people that are Medicaid that are being paid with tax dollars, their care is, and you treat those people differently. You get them to the right place, the right food, the right, all the social determinants of care.
Yeah.
The money you're spending as a state goes down. So,
but I understand that. I understand that.
That's all I'm saying.
Yeah, but it sounds to me like what you're saying is that if the state reduces the cost of the state employees' medical care, that the funds then that are left that had been saved could now be spent by the state or the city on a indigent support program. And to me, that's the government.
That's part of it. That's part of it. But that aside, how much money are we spending right now taking care of those people? How many tax dollars are we spending right now?
I don't
know what it is, but it's a lot, right?
Okay.
And you could say that's socialism because we're all throwing money into the pot to take care of these indigent people, right? And they're getting the most expensive care you can possibly get.
Can you hold that thought? Can you hold that thought,
Sure.
Terry? We got to take a little step aside here for a second. We're listening to the Dr. Larry Show on the Bachelor News Radio Network. You're listening to the Dr. Larry Show on the Bachelor News Network, and we have a discussion going on the financing of the indigents who are now being basically taken care of by the hospitals, who in turn inflate their fees so they can afford to take care of all these people. And we're getting to the issue of let me just mention where I'm coming from. I'm coming from a state program that runs something like uninsured motorist sort of thing. That we would have a small per capita tax on people that do have health insurance, and that they would go into a special fund, and then that would be administered probably by the Medicaid people who now don't have federal money, so they've got something else to do. That's my simplistic thought.
Well, and however you tax people, that's just another way of taxing people. I'm not talking about how we tax people.
Yeah.
I'm talking about how we spend those tax dollars. And I'm saying right now, the way we spend those tax dollars is ridiculous. Believe me, Aaron and I are about as far from socialized medicine or one-payer government pay as you can get, because that would be an absolute disaster. We've got to learn how to provide care a lot less expensively, and it's possible. I mean, it really is, and particularly for the indigent care people.
Okay, I'm going to change.
Expensive, okay, go ahead.
I'm going to change the topic here because we're starting to run out of time. One of the things that we have talked about off the air is that we are living in this year of 2019, and for the next 15 months or so, in a very interesting political era in which we have one party that is talking extensively about the whole healthcare issue, and their solution, of course, is basically socialized medicine. And then the other party is they're not talking about it at all. And it's my assumption that at some point the Republicans are going to have to answer what the Democrats are proposing, and that I don't hear, and I don't know I'm not an expert on this, but I don't hear any ammunition being gathered in the way of a viable program as an alternative to the Democrat solution. And so what I'm wondering now is have you guys seen any? You've seen a lot of individual incidents and situations where there have been what you call disruptive and creative solutions that are being tried. Have you seen any coalition of this that would allow us to provide some kind of a structure or a proposal that would that could be implemented and could become the horse that the Republicans ride? I say Republicans because even though there are a lot of Democrats that don't want socialized medicine, the fact is that all of the presidential candidates are talking about it, and it just seems like there's a real opportunity here, but we need some kind of groundswell, and I'm just wondering what kind of experience you guys are having in that regard.
Yep, Dr. Larry, let me take a shot at that. So, most fundamentally, the issue or the challenge with healthcare is that it's unlike any other industry, where nobody knows what anything costs. The providers that are providing it don't know what it costs. The consumers, it's very difficult for them to find out what something costs to be able to compare, to be able to act like consumers in the first place. There are organizations like Health Rosetta, Healthcare Blue Book, the Free Market Medical Association, Fair Health, others like that are trying to make some sense out of healthcare pricing and give people information that will allow them to make smarter healthcare decisions. What the government could do is push toward that and emphasize that. There are other providers out there that I call them free market providers. They have their pricing, it's posted. What the government could do and should do is look at those providers and say, this is what we're going to reimburse for these procedures. Hospitals, you need to get yourselves in line with this, because if this organization can do it for this price, you're not going to be able to charge 2, 3, 4 times that. We're simply not going to pay for that.
We have laid out a lot of ideas in our book, Larry. I mean, a lot more than we've talked about tonight. And we would love to get this book. And not that it's all the answers, but there's a lot of good answers in it. It's not just beating up healthcare. We've laid a path for, to follow. And we'd love to get this in the hands of the politicians and people that can make a difference. They need to be educated about how healthcare needs to be managed, not just paid for. And so that's one of the things we're one of the reasons we wrote the book, and one of the things we're trying to do is get the word out.
Well, that leads to my next subject, and that is, tell us how to get a hold of your book, and you've been very impressive tonight in your mastery of the subject, but we still need to know. We need to tell the audience how to get a hold of the book and how to maximize the wisdom that you guys have been put on paper.
Well, sure, Dr.
Go ahead, Aaron.
The book is Healthcare is Killing Us, The Power of Disruptive Innovation to Create a System That Cares More and Costs Less. It is available online now at Amazon. It's available in a print, hardback or paperback. It's available in an ebook as well as an audiobook.
And is that?
And our website is www.healthcareiskillingus.com too. And they can go there as well.
Also order from there.
But if you just go on, if you just go on Amazon and put in "Healthcare is Killing Us," it'll take you right to the book.
Good. How's it doing?
Well, the audio just came out about 2 weeks ago, and the book just came out. What was it? 1st of July. Aaron?
Yes.
So we're getting pretty good traction. We're getting pretty good traction just trying to get the word out. We're learning more and more, like you and I talked the other night about how to get the word out on a book. But we've had some impressive calls and people who are interested at pretty high levels. So we're hoping that it'll have an impact.
Well, we feel that we're privileged to try to help you in that cause. We have the custom on this program to give the last minute or two to our guest and let you talk about anything you want to talk about. And so we'd like to hear what's your biggest peeve right now.
Go ahead, Aaron.
Well, it's just the responsibility that everyone should have for their own health. And unfortunately, the system that we currently have allows people to slough that off to, oh, my insurance company will cover that, or the government will take care of that. And we haven't acted like responsible consumers. And again, the industry has made it difficult for us to do so. But many, many people, and you talked about the indigent care, you talk about people that get cancer. That's tragic, and we need to deal with that. But the vast majority of healthcare spending is spending on things that are preventable if people would just change their behaviors.
So that is one of the real keys, isn't it, to reducing that cost? And I think that our audience by now, if they've been listening over the last few weeks, realizes that the practitioners actually only take about 20% of the entire cost. So if we can get rid of some of the other overhead, we can probably do a great job all around. So I want to thank everybody. I thank you guys for coming on the show and for all the great work you do. And we certainly hope that our audience will go out and take advantage of the availability of your book. It's very readable and it's very passionate. And this is Dr. Larry Fedewa. I'm available on my website is drlarryonline.com, and also we are podcast now on the YouTube look under YouTube, and then when the subject comes up, try Dr. Larry and Dr. Cragen or one of the other people. So we'd like to thank you guys and say goodnight to all of our audience, and God bless the United States of America.
Well, thank you, Larry. We appreciate it.
Thanks, Dr. Larry.